This morning, a woman heads to surgery to receive a new heart at one of the top 10 heart transplant centers in the country. And Ken takes the mound less than 1 year after receiving a new heart where he thought he'd never pitch again. Later that morning, our surgeons are repairing the damaged heart of a 3-month-old boy at the largest pediatric cardiology program in New Jersey. And 5-year-old Amari is heading to his first day of kindergarten like any other healthy 5-year-old boy after receiving surgery to repair a hole in his heart. This afternoon, we are harvesting vegetables from our hydroponic greenhouse, which yields more than 5,000 pounds of produce each year. And a high school senior named Jordan is learning the nutritional value of okra. This evening, Lois is prepping for surgery to receive a double lung transplant. And Craig is accompanied by his guitar instead of an oxygen tank. All day, every day, Newark Beth Israel Medical Center and Children's Hospital of New Jersey are committed to providing best-in-class cardiac care, excellent pediatric medicine, and cutting-edge transplants. We are a teaching hospital offering state-of-the-art care in more than 30 specialties, and an anchor institution that thrives on empowering our neighbors and partnering with our community to live healthier together. Newark Beth Israel Medical Center and Children's Hospital of New Jersey. Let's be healthy together.
Good evening. I'm Darrell Terry, President and CEO of Newark Beth Israel Medical Center and Children's Hospital of New Jersey. First, I want to thank the panelists for taking time out of their busy schedules to host this event. As you can tell from the title of this webinar, they have been pretty busy. 6 transplants in 6 weeks is pretty amazing stuff. In fact, you should all know that in the midst of the pandemic, our heart failure program never shut down. We took every precaution that we could to provide care for our patients in a safe manner. In 2017, we celebrated our 1,000th heart transplant and became one of only 12 centers in the nation to have performed that many transplants. Since then, we've also completed recently our 150th lung transplant. I say, even with the changes in allocation, and even with faced with the pandemic, our guys have been pretty busy. I am very proud of this program. This is a differentiator for Newark Beth Israel, and it really does stand out as one of our premier programs in the state of New Jersey. We have added new talent to our team that you'll hear from shortly. And I'm going to let the panelists lead this program and tell you more about 6 transplants in 6 weeks. Thank you guys very much for your time and attention.
Thank you, Mr. Terry. Thank you. And thank you everyone for joining us this evening. I'm Linda Kamate. I'm the Director of Public Relations and Marketing at Newark Beth Israel Medical Center. And I'm also going to be the moderator for this discussion today. And I will be monitoring the chat. So if you have any questions, please shoot them over, and we hope to be able to answer all of your questions tonight. Unfortunately, Dr. Jacob Leff and Dr. Hochbaum could not be with us today, but at the end of the discussion, we will provide information so that you can reach out to the entire team if you would like to. So let's begin. Dr. Kapoor, you are the Interim Director of the Advanced Heart Failure Treatment and Transplant Program here. Can you give us sort of an overview of the program and how it's been doing in the last year?
Definitely. Good evening, everyone. I am Saurabh Kapoor. I joined NBI in 2017 after I completed my Advanced Heart Failure Transplant Fellowship here at Newark Beth Israel. And I have been very fortunate to work with an amazing team of highly competent people. We are one of the high volume centers in the region, in tri-state area. NBI is the only program in New Jersey that does combine heart, kidneys, and heart lung transplants. In 2019, we did 37 heart transplants with the survival rate equivalent to transplant centers and programs throughout the United States. 2020 was a tough year because of COVID, and the transplant volume throughout the nation had seen a significant drop. But we continued doing our transplants, and as the situation with COVID improved, we resumed transplantation, and we did 6 transplants in past 6 weeks. Though COVID has been tough time for everyone, but it has given us the opportunity to strengthen our outreach through telehealth, and we have built a robust telehealth program here at Newark Beth Israel so that we can promptly evaluate and treat all the patients and do necessary for the community. Another highlight I would like to mention of our program has been managing restrictive cardiomyopathy patients like amyloidosis and sarcoidosis. We provide them the latest treatments available medically, and if the patients continue to worsen and reach a point where medicines fail, then we have been able to successfully transplant both patients with amyloidosis and infiltrative cardiomyopathy like sarcoidosis. Another highlight of the program is we have a good track record with patients who are even in their 70s, like nicely chosen patients, and we have had pretty good outcomes with those patients. Yeah, with that, I'll let my other panelists talk a little bit more.
Thank you, Dr. Kapoor. It's really great to hear, how we're keeping our patients, the ability to take care of our patients using telehealth, and to hear some of those numbers and those outcomes. Dr. Camacho, you've been with the program for a little over 16 years now.
That's right.
Can you tell us a little bit, tell us a little bit about your experience and
Oh, yes, absolutely. I'm Margarita Camacho. I'm the surgical director of the cardiac transplant program here at Newark Beth Israel. And Linda's right, I've been here for 16 years. It has been amazing. As Mr. Terry mentioned, we celebrated a milestone 1,000 transplants in the middle of 2017. To date, we have done over 1,100 transplants. I've performed about almost 650 of those transplants. I have to tell you that there is no way we would have achieved these milestones without our team standing on the shoulders of an incredible infrastructure here at Newark Beth. People who rise to the occasion, are so proud to be part of the program, and just are thrilled to see these super sick patients come in and walk out of here all pink with beautiful new hearts. We actually distinguish ourselves as a transplant program compared to other programs in the country by not only taking care of patients with unusual reasons to need a transplant, as Dr. Kapoor mentioned, sarcoid, amyloid. We also do very high-risk patients, and we do patients that are older, something that the vast majority of programs in this country really don't do. And so one of those patients was one of our 6 in the last 6 weeks. Gina was in her late 30s. She's an EMT when she all of a sudden developed such severe cardiomyopathy that she was totally unaware she had, and was actually so sick that she needed to have a left ventricular device inserted. This is a pump that's implanted in your body, and it takes over the work of your failing left ventricle. And it's a pump that you can go home and live with and actually have a fairly decent quality of life while you're either waiting for transplant, or it can be durable therapy. So this occurred a couple of years ago, and we were asked to see her in the fall of last year to work her up for transplant. The etiology of her heart failure turned out to be sarcoid, as we mentioned, an unusual reason to need a transplant. And so after we worked her up, we placed her on the waiting list just a few months ago, and received a wonderful donor offer for her. And, just recently transplanted her, and she was able to go home in just a little over 2 weeks after the transplant. The patients with left ventricular assist devices that need to have a transplant happen to be one of the highest risk, if not the highest risk, patients needing transplant. The reason for that is that the surgery is extremely complicated, not just due to the tremendous scarring that's caused by these LVADs, we call them, these pumps, but also because of the physiological changes that can happen in your body due to these pumps. So we distinguish ourselves as a program by being able to offer such a broad scope, okay, of services to heart failure patients and to various types of heart failure patients that really would not necessarily have been candidates at other centers.
That's great. And I know you talked about the LVAD. I know, Dr. Montgomery, when you joined the team last year, your focus is really handling these types of patients that need these types of coronary interventions. Can you tell us more about that?
Sure. So thanks, Linda, and good evening, everyone. So yeah, my name is Matt Montgomery, and I'm one of the heart failure as well as interventional cardiologists here at NBI. And I've been here for about the past 5 months. So I am the newest member of the team, but I will say that, I felt very integrated since the first day. And I joined the team this past September, shortly after completing my interventional fellowship as well as my heart failure fellowship here at my heart failure fellowship at NBI a couple of years ago. But I will say that it's no secret that this program has a very rich history for providing advanced heart failure therapies to patients not only in this community of Newark, but nationwide for decades. And since starting here, I've been very, very impressed with the perseverance and the hard work, and really just the dedication of our entire team, as well as the clinical care that we've been able to provide our patients. And given this current environment with the pandemic and all the choice that our patients have on places to go, it's just very good to know that our program is still currently thriving. And so, mentioning or getting to the advanced therapies of heart failure or heart transplantation, as well as left ventricular assist device, which Dr. Kapoor and Dr. Camacho spoke about, these treatments are ultimately definitive therapies for patients that have refractory heart failure. However, there are a number of therapies that are along in this treatment paradigm that we can initiate for patients that do have heart failure that we offer here at our center. And just to name a few, for our patients that have underlying coronary artery disease, and as the etiology of their cardiomyopathy, myself, along with our other interventional colleagues, which we work very closely with, are able to provide high-risk interventions or percutaneous interventions and really open up those blocked arteries for the patients, either using an Impella device or ECMO device to help ultimately, which device can help to take over the function of the heart during the procedure to really offer the ultimate safety for the patients during the procedure. And also for our patients that have valvular heart disease in the setting of heart failure, we also have a very active TAVR as well as MitraClip program here at the hospital. And then, for patients that, are, living at home and we're having a lot of trouble, managing them as an outpatient because, these heart failure patients are very complex and are on a lot of medications and their volume status can be difficult to manage. We also offer a procedure or a device called Cardiomyopathy, which is really a sensor that we place in the pulmonary artery, which is in essence allows us to be able to manage these patients in the ambulatory setting and get a better idea of their volume status to ultimately help them to feel better and to keep them out of the hospital. And then in conjunction with all of these, we're part of a lot of numerous clinical trials, which, ultimately will provide, some new cutting edge therapies for our patients to help them to be able to feel their best and that may not be qualified for other therapies. And these include therapies for amyloid as well as for other cardiomyopathies that Dr. Kapoor and Dr. Camacho have spoken about. And so with these therapies, all of them are predominantly focused on, dealing with patients that already have advanced heart failure. And so But the question also often comes up about when to ultimately refer these patients to an advanced heart failure center and when it's appropriate for them to be evaluated by our team. And so, you know, can be summed up in a simple algorithm, or something called, I need help, which essentially goes through a lot of other signs and symptoms that patients may have, such as the need for, outpatient medications or inotropic therapy to help their heart function well. They have very depressed ejection fractions. They have ultimately end organ damage from their heart failure. They're getting shocked multiple times by their defibrillators. These, along with many other things, can be signs that patients may need to be seen by an advanced heart failure center, ultimately our center here, that we can offer them a lot of these advanced treatments.
That's great. I just want to reiterate, I know a few people joined after we started the conversation. I am actively monitoring the chat, so if there are any questions, please feel free to put those, to send those over to us so that we can respond. Dr. Montgomery, thank you for sharing that with us. Dr. Camacho, I just wanted to turn it back over to you. I know that Dr. Montgomery talked a lot about the different interventions, and one of the patients in particular, Gerald, I believe 26 years old, we did have to use a lot of interventions with him. Can you talk a little bit about that case?
Yes, sure. So my partner, Dr. Jacob Bluff, I'm sorry, couldn't be part of this webinar because he's doing an emergency cabbage right now, but he joined us last year in May of 2020 as a director of mechanical circulatory support and ECMO. And he came to us from Montefiore, where he was for 13 years, where he did a lot of adult surgery, including heart failure surgery, but was also the director of their ECMO program for 10 years and had it grow from 4 cases a year to 93, I think, the year he left. So he brought with him that expertise and a lot of experience as a program director for that ECMO program. And I mention this only because that's exactly what Gerald needed. Gerald came to us with advanced cardiomyopathy. He had been known to our heart failure service for quite a while, but he came to us when he had, as many of them do when they're young, they look good, and then all of a sudden one day they tip over. And so the first thing he got in our algorithm for him was an intra-aortic balloon pump. We worked him up quickly for transplant, listed him, but he started to dwindle even with the balloon pump and 2 inotropes. So he received an Impella, and while on the list, still, got sick fairly quickly, and so he had to be placed on ECMO. And he wasn't on all the support that long, but he just deteriorated that quickly. So that's why we had to progress from, a simple thing like a balloon pump to all the way to ECMO. We then, when he was on ECMO, a few days later, we got a really good donor offer for him. And by that time, he had, as I said, he was deteriorating pretty quickly. He was about to get intubated when he was brought to the operating room. Thankfully, we had a donor offer in the nick of time. He went to the OR. Dr. Jacob Bluff transplanted him, and he went home, I think, just a little over 2 weeks later. This is an example of something we've seen many times in this program. Patients that are so sick that cannot wait for a transplant. They need mechanical support, but they often need more than just an intra-aortic balloon pump. And one of the keys with providing enough support is knowing what device to put in a patient. So, had we not had this armamentarium of devices, you start with the simplest and then, work your way up if you need it. And had we not had all that, I don't know that he would have survived a transplant. So, this program has a very rich history in mechanical support, not only with the temporary support that we just mentioned, but with the implantable durable devices. Again, I've been here about 16 years, and from even before I arrived here, just about almost every FDA trial came through this center. And so we were privileged to be able to offer devices, the newest devices in clinical trials to patients who otherwise would not have access to them had they been at a center that was not in the clinical trial. And I know dozens of patients that we have implanted during clinical trials that would have died if we didn't have those devices on the shelf to offer them. So, I think Gerald is just yet another example of someone who really benefited from a program with a very strong mechanical support, perspective.
That's amazing, Dr. Camacho. We do have a question from our participants here. Do you anticipate an uptick in heart and lung transplants for COVID survivors? And will you transplant an organ from a COVID donor or into a COVID positive recipient? So I'll just throw that out to the entire team.
Well, for the COVID, we specifically make sure the donor doesn't has COVID. The COVID positive donors are not accepted at this time because transmitting COVID and all its manifestations, which could be cytokine storm and everything, could be very detrimental to a transplanted patient who is severely immunosuppressed. So yeah, we don't do COVID positive donors. We have it has been trying times right now. Some of our transplant patients did while waiting on the list turn COVID positive. We had to wait until they cleared up the COVID. We had to very closely monitor them, but we were able to successfully, once they cleared off the COVID infection, we successfully were able to transplant them, and they are doing excellent.
Great. Thank you, Dr. Kapoor. That's a great segue to our next discussion with Dr. Gomez-Abraham. Dr. Gomez-Abraham, I know before today we talked about how important patient selection is to our success, and I wondered if you'd talk to us a little bit about that.
Yeah, good evening. Thank you for having me. I joined the program back in the summer of 2019, and I came to Beth Israel because, as Margarita have mentioned, the tradition, the cohesiveness, the advocacy, and the deep care of the community and the patient transplanted. I came from Temple University, and before that UCLA, so I had been in 4 of those more than 100 heart transplant programs. And that's what makes it a very unique way to where did you go, and it was easier transition for me because of that. When I joined, it was a transition point also, because at that point, half a year before, in December of 2018, the regulatory agency of UNOS had changed the classification of the listing. So therefore, we had to adjust, implement different strategies in order to make sure that the survival and the volume of transplant would continue. And I think that it's very important what Margarita was saying, that you have to have the armamentary and the tools and the devices that are appropriate, because as a result of the changes, the majority of patients that get transplanted in the United States are patients that are inpatients. And as we saw in these cases, patients sometimes deteriorate, and you need to change the strategies and have to have the best available tools to make sure that not only the heart, but also the multisystemic organs are preserved so that they continue being a good candidates for transplant. So I think that's a very important point to make in that transition point. Now we have to add lately to the COVID issue. So that was a very difficult time, because then because as a result of the changes, we needed to travel a little bit more distance to get organs, and that makes also a barrier in the COVID situation. But regardless, as Mr. Terry said, we perseverated, we continue with the basic strategies, and we were able to continue transplanting in order to get those 6 transplants in the 6 last weeks. Another important point that I want to mention is that we offer, as Dr. Kapoor had mentioned, we offer dual organs. So we have a program for heart and kidney, and we have a program for heart lung. And I am very involved in that program, and in which recently we have a patient that was transplanted last summer, a patient with pulmonary hypertension as a result of Eisenmenger syndrome with a congenital disease, with a very, very good results. The patient was told for early on that he would not have a much survival, and so he persevered, came to MBI. He was properly evaluated, and we did a transplant, and gratefully he is in the Healthy Together Winter Magazine section, and he is in the last part of the magazine. So it's a very nice article that they did, and he's also illustrated in our RWJBarnabas portal, in which, you know, just making sort of like a summary, as Dr. Kapoor had mentioned. We do very complex cases. Dr. Camacho is just an example of all the hard work, and that makes it easy to work all together in this cohesive and very appropriate team that we advocate. Finally, just think about it. Margarita, we were talking before we started this, the program has performed 1,114 cases. That led with the majority of about 1,000 patients have done very well with a survival of more than 1 year. And even despite of the changes, even despite with the COVID, we keep a survival over the 90%, even despite that the national average is inferior. So imagine that over 1,100 cases, 1,000 has survived very properly over the year after transplant. That is a remarkable numbers.
That's great. That's great. We have another question from our audience here about referrals. And the question is, two-part. What is the relationship between the referring doctor and the team once they refer a patient over? And what's the wait time to be seen for the patient to be seen once they're referred over?
So the referred patients, we usually like to see within 1 to 2 weeks time. And if it is an urgent patient, sometimes they are referred just from within the hospital, and we transfer them to Newark Beth Israel directly. But yeah, for our goal is to see the patients within 7 to 10 days. And then one of the important things with the once we evaluate the patient, there are some patients which we can stabilize them, and some patients we just need to closely follow up, but they don't need immediate heart transplant or a left ventricular assist device at that time. So our goal is to have the patient follow closely with their primary cardiologist, but see us intermittently so that we keep a close eye on the patients. And if they start deteriorating in their clinical course, then we jump on it so that we can quickly evaluate and put them on the list. But not every patient that is referred would need a heart transplant. Some of them can be optimized and very well cared by the referring physician, and with a close follow-up with us.
Thank you. So I'm just checking the chat here. I have one more question here. Would a TransMedics or similar box give you the ability to increase the reach of distance you can travel to procure a heart? And are you taking offers from DCD donors or DBD donors?
I might just say something because I was thinking about that. Margarita can complement. But interestingly enough, Margarita and me were initially at that point, Margarita at NBI, but I was at UCLA, and we were participants of the OCS, or the Heart in the Box technology. And
the first phase, actually.
In the first phase, that's probably about 20 years ago, Margarita, when we started it.
No, it was about 10 years ago, but it was the phase one, it was the safety part of it.
With
There were only
the
7 institutions that were involved, and yours and mine were Beth Israel and you're at UCLA, right?
Right. So recently, Margarita and me, we talk again, and we are very interested in the new trial of the DCD donors. And actually, Margarita was participant. She can talk a little bit more about the IRB and so on. But we're looking very much forward into using that as well.
Yeah, so Jesus and I looked at this very actually, we were ready to embark on it, and then COVID happened. And so everything sort of came to a screeching halt. So it's very timely question, because we were just emailed by the company a couple of days ago to find out if, we want to reopen, evaluating whether to be part of the trial. And it's, I am a big believer in the device. Okay, I used it, I think, about 8 times, and it's incredible. I mean, yes, you can go to Hawaii to get a heart. I mean, it decreases your ischemic time to about an hour and a half for every single patient. They used to, and they may still use it quite frequently in Australia, where Australia is the same geographic size as the United States, but as you know, everybody lives in the periphery. So I had to lecture in Australia. It was about 10 years ago when I was doing this OCS trial, and they were flying and having ischemic times that were insane, like 8 or 9 hours, and everybody wound up on ECMO afterwards because there were such long ischemic times. So I suspect they love this device because now they can travel without worrying. Yes, I think there's a future for this. We have turned down many hearts from places like Puerto Rico because it's too far to travel. This will enable us to accept those hearts. And the new part of this current phase of the trial is to try to optimize marginal donor hearts using this system. So it's sort of like supporting the heart on, like, whatever you want to consider it, like ECMO or bypass, to see if marginal hearts actually recover on it, which would also help increase the donor pool.
Thank you. Thank you. So I think this has been a very informative conversation. I want to thank all of you for joining us today, for taking time out of your schedule to participate in this, and thank everyone who joined the chat session to hear about our program. Any final thoughts? If there's any last words, that you really want to impart upon our audience this evening, I'll throw it out to everyone.
I would like to emphasize all the options that the program offer, from the point of view of mechanical circulatory support, as Margarita was saying, to the very comprehensive and cohesive and very complete evaluations that patients get to be listed, and the appropriateness of the patients to be selected and properly managed following the new bylaws and the regulatory issues and guidelines by not only the federal agencies like UNOS, but also how we adhere to the HSLT, or the International Society on Heart and Lung Transplant, and the ethics that gets involved. So I think that that is something that we need to outline, and it's very remarkable, the job that the program has done, and we continue to pursue to do it for the years to come.
I would also like to mention that as a part of advanced heart failure therapies, we do, for the referring hospitals, we want to work as a spoke and a hub model where the referring hospitals can send their sick patients to us. And not every patient needs a heart transplant or an LVAD. Some of them we can stabilize with shorter mechanical circulatory support devices like a balloon pump, Impella, or even ECMO as a bridge to recovery. And with recovery, once they recover, they go back to their good medical treatment, back to the referring cardiologist, and close follow-up with them. So there are definitely options in cardiogenic shock which we can offer here at Newark Beth Israel.
And then also, I'd like to just follow up on that too, and just say that and emphasize that our goal as an advanced heart failure treatment and transplant center is to, work with the referring cardiologists, not just the ones that send patients here as a transfer from another hospital because they're in cardiogenic shock or they need some advanced support that the referring hospital is not able to offer, but also your patient that's in the office that you think may be sliding a little bit, that may be becoming more and more decompensated. It's always best that we see those patients early. And it's always best that we're able to evaluate them early, because if we get ahead of the curve, we can follow them closely with you as a referral. And then once, like Dr. Kapoor said, once they start to slide more, then we can jump in and take action. We already know the patient, and it's a much more seamless process than to see them ultimately when they are, in a very, very sick and compromising state. So I think it's just something to emphasize that we're here to work with you, and we're here to provide ultimately the best care we can for the patients in this area.
And just to follow up on what Matt was saying, we have over the last year really streamlined our referral process and our transfer process. I mean, we have an extremely efficient and hardworking transfer center. And Linda is going to be providing our contact information, but you can call any of us. You will have our cell phone numbers. You can text us, call us, email us, whatever form of reaching out to us you want to use. And if you don't get one of us, call one of the others. I've had cardiologists call me and not another cardiologist first, just because they either know me or it was easier to reach me. And I've actually occasionally been the first line person to see a patient, and I'll do it either in person or a televisit just to make the connection. So that's why we can see patients so quickly, because we want to do everything we can to make that connection with them as soon as possible. So when Saurabh said 7 to 10 days, that's the max. I mean, we can probably see them sooner, and certainly if you ask us to, that's no problem at all.
Nice, very nice. We're going to just take one last question here, and then we'll wrap it up for the evening. What are the most common reasons for not taking a referral for advanced heart failure?
It's a question, like some of the patients we cannot. So one of the things, what makes a good candidate for advanced heart failure therapy? So the biggest thing which we look into, compliance of the patient, substance abuse. If the patient is using illicit drugs or recreational drugs and is not compliant with the treatment, then they can't be listed for a heart transplant or an LVAD, because the outcomes are very inferior, and patients, we will do more harm if the patient is not compliant with the treatment with these therapies. So that is one of the biggest roadblocks for us. So that's why sometimes we try to stabilize these patients on an inotropic support and follow them closely as an outpatient. And if they show compliance, and if they show that they have taken actions to stop the substance abuse, then they can be evaluated in future for these therapies.
Thank you. Well, we have come to the end of our session. I just want to thank everyone again, and thank you all for your questions. Everyone who's attending today and who registered for the event will receive a link to this video. And if you are looking for more information about the program, we do invite you to visit our webpage at rwjbh.org/NBI Heart Transplant. And if you would like to refer a patient, you can reach out to the team directly at 973-926-4189. So that information will be up for you to see for a little while after this chat. And thank you, and have a good night, everyone.
Thank you.
Good night.